So I'm really thrilled today to have wrangled Dr. Lauren Harshman for an interview. Dr. Harshman is an assistant professor at the Dana-Farber Cancer Institute, focusing on kidney cancer. And I have to tell you, if I had to put my bets on the one person that's going to cure kidney cancer within the next 30 years, I'm going to put the onus on her. I think she could do it. So Lauren, thank you so much for joining me today.
Thank you, Monty. It's a pleasure to be here.
One burning question that we were all sort of left with after the presentations is, how might some of these combinations be moving ahead? Did they allude to any trial designs that might be moving forward?
So the other two studies that were presented were actually, it was one study that was kind of cut into two because of the different combinations that were tested. So Dr. Amin and colleagues presented the results of trying to combine the nivolumab with two established targeted therapies, pazopanib and sunitinib. Dr. Hammers just several hours ago presented the results of the combination comparing nivolumab and ipilimumab. Ipilimumab really is actually an antibody to CTLA-4, and it actually it basically takes the brakes off the T cells. So another way of stimulating the patient's own T cells to fight the cancer. And so in the first study where they combined it with the Sutent or pazopanib, the major questions when we try to combine drugs is, can we get additive or even better synergistic efficacy or effectiveness, but is it at the expense of tolerability and toxicity, and can we find a happy medium? And what they found when they tried to combine nivolumab with pazopanib was that it actually was probably too toxic on the liver. So that combination is at least not moving forward with nivolumab right now. Other studies with different PD-1 blocking antibodies like the Merck compound are looking at it. When they looked at, the results with sunitinib and nivolumab were more promising. Response rates in over 50, patients had significant responses in over 50% of the cases. We don't have data on overall survival just yet. Progression-free survival, meaning time to the disease progressing, was over a year or close to a year, and so that's also promising. But I think these were small studies, and we need more data, and we need to see them tested in hundreds of patients. I'm not sure where the compound is going. The BMS compound, the nivolumab plus sunitinib, they haven't sort of told us all that yet, but I do think that we have multiple trials now ongoing investigating different PD-1 blocking antibodies, whether it's the Merck compound, BMS, or Genentech, with different TKIs, whether it be pazopanib, bevacizumab, the antibody to VEGF. I think what we do know, though, is the data from Dr. Hammers today, where they combined these two T-cell stimulating therapies. Okay, we have nivolumab that's blocking PD-1 and that negative interaction, and then ipilimumab, which is unleashing the T cells, so to speak. And what they saw there again was this exciting response rate, or basically significant tumor shrinkage in close to 50% of the patients, over 40% of the patients. And these were a patient population where 80% of patients had already had at least one line of therapy. So again, that is exciting when we look at other second-line targeted therapies and response rates from those. The question with this combination, though, is it toxic? And these are some tough drugs. Ipilimumab, can have some significant diarrhea. And they did find, at least at the higher dose of ipilimumab, that there were 60% of patients having some significant grade 3 and 4, which means in our world, higher toxicity rates. But at the lower dose of ipilimumab, they had a lower rate of those high degree toxicities. Either way, what the investigators reported was that these were generally reversible and manageable toxicities. So that's always going to be important, is education in terms of the physician being able to give these drugs. So if they are more than additive in terms of effectiveness and we can manage the toxicity, then it's really realistic to move them forward. And I do know, as was presented by Dr. Moser and Dr. Hammers, that they are thinking of taking this forward into a phase 3 trial, looking at the combination of nivolumab plus ipilimumab in a much larger set of patients.